To approach the oral cavity, it can be difficult to get the tumors out, in this patient especially because she's post-mortem, everything is very tight and rigid. So what we're going to do is we're just going to basically do what we would call a lip split, which this is a good way to get at the oral cavity. So we're going to split the patient's lip, and this is how I'll approach tumors in the mandible. And so we'll cut the lip. We can come around the chin and get exposure to the oral cavity this way. So I'm coming right down to the jawbone, okay? And obviously, I've cut into what would be the oral cavity mucosa, and we're just sort of peeling that away there. So now you can see the jaw pretty well, okay? So this is the mentum of the jaw, so the submental area is here. If we look into the oral cavity here, we can now start to see the tongue here. Underneath the tongue, on each side, which you can't see them very well here, but they almost look like little snake eyes. And if you look at yourself in the mirror, you'll be able to see them, but you'll have the ducts of the submandibular gland. So that duct comes from the gland, which is in the neck, underneath the mandible, and out into the oral cavity here. So last week I had a woman who has Sjogren's syndrome and gets a lot of dryness of the mouth, and she formed salivary stones. She was getting infections in her right submandibular gland, so we took her to the operating room and took out the right submandibular gland, and she had a large stone in the gland at that time, but her duct was still in place. She developed 3 stones in the duct. So we took her back to the operating room and we opened up the duct and we were able to get submandibular gland stones out. So the blood supply to the tongue is primarily from the lingual arteries, which come off of the external carotid artery. When we go back to the external carotid artery, when you get to the bifurcation of the carotid, remember that there are no branches of the internal carotid artery in the neck, just the external carotid artery, and the lingual artery is one of the branches, one of the 8 branches of the external carotid artery, and that supplies blood to the tongue, okay? The anterior 2/3 of the tongue gets its taste, your ability to taste comes from the chordotympany nerve, which is a branch of the facial nerve. It goes through the middle ear space, and it goes in and ultimately feeds the tongue. And then the posterior 2/3 of the tongue come from the vagus and the glossopharyngeal nerves. When kids have ear infections, that can weaken some of the taste fibers of the chordotympany. And then when we do a tonsillectomy, we can cause some irritation to the glossopharyngeal and vagal supply. So a lot of patients after tonsillectomy will have transient dysgeusia. Their taste sensation will be off because of irritation of those sensory nerves. And sometimes patients with bad ear infections will get loss of their taste. That's a little bit different than when patients have sinus infections. A lot of patients will come in with sinus infections and say, oh, I can't taste anything. And no, they can still taste. We can taste salt, sweet, bitter, and sour. Our olfactory sense, that augments taste to give us flavor. So when you get a sinus infection, it impacts olfactory function, and it throws your sense of taste off. But with those patients, you will have the ability to taste strong things, something very salty or bitter or sour. Now, with the tongue itself, there are 2 different types of taste buds on the tongue. The majority of the tongue is covered by the fusiform papilla, and then in the back you have the circumvallate papilla, which is a little difficult to see on her, but the circumvallate papilla look like little mushroom caps along the back of the tongue, and they're very symmetric. We will often get patients that come in concerned about a mass because the taste bud got inflamed and they can now see it. And there's this idea that there are super tasters, where some people's taste buds work better than others, and that is completely genetic. And they use that super taster ability in some patients to try and manage chronic pain. So there have been some studies where you give patients a lozenge that has a little capsaicin in it, and it can stimulate those taste buds, and it can diminish pain sensation. So let's try and see if we can identify a little bit more here. I'm going to come back a little bit farther. I'm sort of splitting the lip there, pulling it back. Let's just come right through the skin and peel it all back. So this, our technique is a little better in the operating room, obviously, but I will actually do this when I'm resecting tumors. Now look, I peeled the soft tissue back, and look at the exposure to the mandible. So now if I had a patient that had cancer of the jawbone, I could resect that jawbone. I've got great exposure, and then my plastic surgery colleagues could come in and put a microvascular flap there. They might use, if we're taking part of the jawbone, they would take fibula bone with skin and the blood supply. They would be able to attach the blood supply to the great vessels, attach the bone of the fibula to the native bone, and inlay the soft tissue, the skin paddle, inside the mouth, and in that way we can reconstruct the jawbone. And we can get very, very nice results with that. It's a little hard to see because she's really dried out, but just about in this area you would see the duct to the parotid gland. So I told you the submandibular glands, the duct comes out here, the parotid duct is up here. The oral cavity is pretty forgiving, and this mucosa is really nice, and you can use it for a lot of things. So sometimes we'll take off a tongue lesion, and we can take a little paddle of mucosa and swing it over. I help Dr. Miller of urology, Kenan Miller of urology, who does a lot of urethroplasties. Men who've had trauma to their urethra and get scarring, I will harvest a large piece of buccal mucosa that he can then implant into the urethra and improve the diameter of the urethra and help with stricturing of the urethra. So this mucosa is really, really nice to use. We can also use this mucosa as a graft. So I've had patients who had orbital fractures, and some of the mucosa healed, scarred in. We can take buccal or paddle mucosa and use it as a graft inside the eye to help improve what we call an ectropion, where the eyelid sort of scars down after trauma or prior surgery. So there's a lot that you can do with this, and it's pretty forgiving. In terms of the tongue itself, it's very well vascularized. So in a lot of patients that have cancers in the head and neck area, in the oral cavity, if you strip the mucosa off, within a couple of days it starts to remucosalize. So well, the blood supply is so well defined. So rarely do you have to put a graft in there. Occasionally, I will use a skin graft or cadaveric tissue to reconstruct the mucosa, but I use that more as a biologic dressing to prevent the tongue from scarring down. If we see if we can lift up the tongue a little bit. So the tongue is made primarily of the hyoglossus and the genioglossus muscles, the mylohyoid muscles, and the tongue is important, obviously, for articulation and obviously for swallowing. It helps us with our oral preparatory phase of swallowing, and that's the only part of your swallow that is voluntary. So it'll help you chew up, move the bolus of food around and pass it back into the pharynx. There's also mucus glands, salivary glands on all of the tissue, which helps lubricate things and pass the bolus of food back. And everyone knows the importance of that. If you've gone to sleep during the winter with the heat on and a cold, and you wake up and your mouth is all dried and cracked and you have trouble swallowing. In terms of articulation, it's important because it helps us form our words. So when you lose your voice box, you can't phonate, but you can still articulate because you have a tongue. If you lose your tongue, you cannot articulate. So this can be devastating to a patient. So we do have patients that get cancers of the tongue, and our first line of treatment is to try and cure them with chemotherapy and radiation therapy, because loss of the tongue can be functionally devastating. So in patients that require a total glossectomy, they will often get a concomitant total laryngectomy, because once you remove the tongue, there's no way for the patient to manage the bolus of food in their mouth, and they're more likely to aspirate and have chronic problems with aspiration. So we will often do a total glossectomy and a total laryngectomy at the same time. In patients that are good surgical candidates, you can take free tissue from different parts of the body and reconstruct the tongue. You can use chest tissue on a pedicled flap, so the tissue has a good blood supply, and put that up into the oral cavity as a big mound of flesh that's going to act as a pseudo tongue. You can take the radial forearm and take soft tissue and reconstruct the tongue in that way, but it's still not quite as good as the original, and patients still struggle to articulate afterwards. So in terms of infection, I told you before that the tongue has pretty good blood supply, so rarely does it get infected. However, the spaces around it can get infected, and that can compromise the venous outflow of the tongue and the lymphatic outflow of the tongue, so the tongue all of a sudden can get very swollen and proptotic. So you can see anything in the oral cavity that puts pressure on the tongue can all of a sudden block the airway and cause a lot of problems.
Do you ever see like pediatric patients with macroglossia?
Yes, so good question. So we see in pediatric patients, we see two things. First is some kids will have a pronounced frenulum on the tongue, and they'll have what we call ankyloglossia, where the tongue is tethered. And when the kids try to extrude their tongue, the tip of the tongue almost dimples. And this can cause a problem with lactation. And some of those kids will also have a tethered upper lip. So we have to release the frenulum there and release the tether here so the kids can feed appropriately. So I will often be called to the maternity ward where the child is just having trouble latching onto the breast, or a new mom will come in a week after giving birth, and we'll release that right in the office or right at the bedside. Some kids, it's not as pronounced, but as they get older, they have some problems with articulation because they can't move their tongue as well. And in those kids, once they have teeth and they can bite me, I take them to the operating room to do the frenulectomy. Some people will also do it with a laser. Some of the dentists and oral surgeons are doing that. I think that's a big fancy piece of equipment that's really not necessary. The scissors works just as well. In terms of macroglossia, you can see that in patients with Down syndrome, where the tongue can be enlarged. Because the tongue is enlarged, that can sometimes impact development of the palate, and some of those patients will develop cleft palates because the enlarged tongue prevents the palate from forming. And with macroglossia, it obviously obstructs the oral airway. So kids with Down syndromes can be a little bit more at risk for upper airway obstruction and sleep apnea related to a large tongue. Now, in patients in general, where the jaw is determines sort of how the tongue sits in the mouth. You look at someone like Jay Leno, and he's very prognathic, where his jaw really juts out. And then you look at like the actor Joe Mantegna, who's on CSI. He wears a goatee because he's relatively retrognathic, and the goatee fills out his face. Patients that are retrognathic, the tongue is more likely to fall back, and those patients are a little bit more at risk for sleep apnea and upper airway obstruction. So in those patients, we will do a genial advancement where we can actually cut the jaw and slide it forward, or a modification of that is we take a circular drill and we take out a piece of the mandible with the tongue attached and we pull it forward. So as we lift up the tongue here a little bit, you can start to see, I'm going to see if I can lift up the mucosa a little bit better, but you can see the fibers of the tongue. And it's just a big muscle. So if anyone's ever bitten into their tongue, they know how much it can bleed. So let's try and just cut the tongue in half so you can get a look at those fibers. So you can see those fibers of the tongue. So that's just all thick muscle. And again, the motor supply comes from the hypoglossal nerve. The hypoglossal nerve is the 12th cranial nerve. It comes off the skull base. It comes between the bifurcation of the internal internal carotid and external carotid artery. It goes underneath the digastric muscle, and it comes up into the tongue to supply the tongue. And also with that is the lingual artery, which comes off the external branch of the the external carotid artery, and it comes into the base of tongue. So you do have to be careful when in some patients we don't have to remove the whole tongue. We'll do what we call a partial glossectomy or a hemiglossectomy, where we'll take out the tongue. You have to be careful that you don't compromise both lingual arteries, because then the tongue will lose its blood supply and become necrotic. And when we do a partial glossectomy, if patients have half their tongue, they do pretty well in terms of swallowing and even speaking. They will have a little bit of an impediment. In some patients, we will offer them reconstruction, where we'll use the radial forearm or the lateral thigh and we'll reconstruct the tongue. And I've had some patients where we can actually make that sensate, and we use one of the cutaneous skin branches and attach it to the nerves in the neck, and this becomes, it can feel heat and cold, and so that helps them prevent them from chewing on it and burning it and things like that. But the tongue is pretty forgiving. So you can take out a big piece of the tongue, leave it wide open, and it'll re-mucosalize and heal up pretty quickly.